the serum creatinine has started to change.
Absolutely. Thank you so much, Dr. Verma. Let me tell you, there are several more questions waiting for you. And I think we're going to go and pose them to you on the chat, and we hope to hear from you. For the want of time, I think we'll move on to our next session. And the next session is going to be our case discussions. And may I request Dr. Hsieh to come in with his case and take it forward from there, please.
Thank you. Can I have my slide? Okay, Mr. Chairman, ladies and gentlemen, I'm Dr. Ming-Hsiung Hsieh from Taipei, Taiwan. It's my great honor to present the case. An elderly gentleman with type 2 diabetes in APAC meeting. Next slide, please. Mr. Su, 87 years old male, he presented to my clinic due to dyspnea on exertion after discharge from our chest ward. He was hospitalized due to community-acquired pneumonia for intravenous antibiotics. At my clinic, he had an irregular pulse and a systolic murmur over apex. A surgical scar was found at the anterior chest wall. Next slide, please. He had a medical history of CAD status post-bypass surgery in 2001, hypertension, type 2 diabetes for more than 10 years, and chronic kidney disease. He was admitted to our hospital due to community-acquired pneumonia in January 2015. 2 months later, he came to my clinic with the complaint of dyspnea on exertion. The discharging medicine included aspirin 100 mg per day, beta blocker, ARB, statin, metformin, and diuretics. Next slide, please. The investigation included 12-lead ECG and the chest X-ray that I will present in the following slide. The Holter ECG showed persistent AF with one non-sustained VT, 10 beats, rate 182 beats per minute. The echocardiogram displayed dilated LA 43 millimeter and the LV and body 56 millimeter with concentric LVH and the hypokinesia in the anterior septum with estimated LVEF 54%. His serum creatinine level is 1.56 mg per deciliter with estimated CCR 42. Next slide, please. The 12-lead ECG at admission show atrial fibrillation with rapid ventricular response. Next slide, please. The chest X-ray 2 months before my clinic displayed cardiomegaly, increased lung marking over bilateral lung field, prominent right lung hiatus, and the blunting of bilateral cost-phrenical angles. The picture is compatible with heart failure. Next slide, please. So now, panel discussion for this case.
Yeah, so maybe I'll start. Dr. Hsieh, this is a very common situation where we have patients who are admitted to hospital for other reasons, for example, like a pneumonia, but then it unmasks the presence of atrial fibrillation. And of course, this patient is quite sick. And so, Dr. Jaswal, I'll let you ask this question about these high-risk patients and how you feel they may be managed.
Absolutely. As you rightly said, that often we pick up atrial fibrillation when the patient is admitted to something else, and even worse, when they present as stroke to a stroke unit. That's the saddest part. So can I have the questions, please? Can you bring on the slide with the question? And I would request Dr. Hsieh to answer the first question as to how does he deal with these patients whom he sees in atrial fibrillation with comorbidities. Dr. Hsieh?
Yes. I raised 4 questions about this case. The first question is, how would you treat this elderly gentleman with diabetes? His CHABA score is 6. And the first question is how do you select an anticoagulant for a patient with diabetes? Warfarin versus NOAC. Which one is better?
Yeah, so maybe I can start with that, Dr. Jaswal. You know, I think, you know, this patient already has evidence of chronic kidney disease. We see the serum creatinine is almost 1.6. The creatinine clearance has already fallen to about 40 mils per minute. And so this is the type of patient, for example, that we saw in the Zerino registry. Elderly patient, diabetic, established chronic kidney disease. And what we learned from the Zerino study is that warfarin is not a good choice for these patients. Warfarin actually accelerates the progression of renal disease, whereas a NOAC like rivaroxaban actually slows down the progression of the renal disease. So, you know, this patient is at high risk of developing end-stage renal disease. He is at high risk of eventually ending up on dialysis. Even though he's very elderly, this may happen within the course of his lifetime if we don't choose the right agent. And in this case, warfarin is certainly the wrong choice.
Yeah, and this also answers one of the previous questions after your talk, Dr. Verma, which for the want of time I did not bring it in. That was warfarin a choice wherein you could monitor the INRs in patients with ESRD and dialysis? I think you already answered it very well, that warfarin should not be the choice of medication in our patients with ESRD. May I request Professor Tan that to what extent do cardiovascular and limb outcomes inform your choice of treatment for atrial fibrillation in patients with diabetes mellitus? Do you consider a change or consider the molecule? Which of the NOACs would you prefer in your patients in diabetes when you want to reduce cardiovascular and limb outcomes? May I request Professor Tan to please come in?
I think I have no compelling reason to choose among the from the randomized control trials. I think it is all NOACs would be good, but as mentioned before, there is some emerging evidence, albeit observational, that the limb events may be reduced. I think that's very promising. But and it will certainly put my vote towards choosing rivaroxaban for such patients. But in general, I'll primarily advocate all NOACs for patients. And for I think in the next case that we will talk about, I think the idea of renal preservation is very intriguing. It is a big problem. The evidence is very promising, and that is actually one of the that may push me towards using rivaroxaban primarily in diabetic patients with CKD. But the evidence again, if you have more conclusive evidence, that would be great.
Yeah, I would agree with you, Professor Tan. But I think, as Dr. Verma did make a mention earlier in his presentation, we are having more emerging evidence, and I think one of the trials, which was not actually for atrial fibrillation, but I think let's bring in here the COMPASS trial. And we have very good data from the COMPASS trial in our patients with peripheral vascular disease. So yes, there is certain amount of evidence which seems to be emerging more and more as far as we want to protect the vascular bed be it in CAD or in peripheral arterial disease, that yes, rivaroxaban seems to be the answer. May I request Dr. Verma to come in here to take on the question as to what are the priorities or the treatment goals that you have when you're managing your patient of atrial fibrillation with diabetes. We've already discussed mostly, but I think we would want to rehear from you to reaffirm in all our minds the treatment goals in this subset.
Yeah, so I think, Dr. Jaswal, as we've talked about, renal preservation is an important goal for any diabetic patient. So anything we can do to prevent or slow down the decline in creatinine clearance is very, very important. We talked about limb events as well, and reducing the risk of limb amputation is very, very important in diabetic patients. One thing we didn't necessarily talk about yet are ophthalmic events. As you know, retinopathy is a significant complication of diabetes, and now there is even some emerging evidence about slowing the in visual status and the progression of retinopathy in NOACs versus warfarin. And I think it's the same mechanism. Remember, warfarin encourages vascular calcification in many different beds, the kidney bed, the limb bed, and including the microvascular bed in the retina. And so I think it's again a proof that NOACs in general are the superior choice compared to warfarin in these very delicate patients.
Yes, and I think before we move on to the next case from Professor Tan, one point which I do want to highlight to all the audience is that we must remember that three things which are most important and we must remember is the CHA2DS2-VASc, the HAS-BLED, and the creatinine clearance. All of them are dynamic, and you must keep re-evaluating them as your patient walks in with atrial fibrillation, because it's going to be changing, and you may want to do it at least 6 monthly to understand the disease process, to understand the molecule that we are giving for the protection of stroke. So I think from here, may I request Professor Tan to come in and present his case, please.
Hi, good evening. My slides. Thank you. Next slide, please. My patient is much simpler and is at the other end of the spectrum compared to the previous case. This is a 58-year-old lady who has had atrial flutter ablated when she was at the age of 42. At the age of 45, she developed diabetes, hypertension, hyperlipidemia, and gout. So our full house, a CVD risk factors. And she was, after a successful atrial flutter ablation, she was off anticoagulation. Unfortunately, she developed a stroke in 2012, 10 years ago. And around that same time, atrial fibrillation was detected on ECG, and she was started on anticoagulation. She developed a minor bleeding complication, hematuria with anemia, and also bleeding from fibroids. But this will resolve, and she was continued on a anticoagulation. And there were incidental findings of renal stones and gallstones. By April of 2019, when she was age of 55, but by which time she has a 10 years history of diabetes, she was found to have incipient diabetic nephropathy. And also at the same time, she had some atypical chest pain. Next slide, please. These are the investigations. At the time of atrial flutter, her EF was normal, her valves were normal, non-valvular AF. And with regards to the chest pain presentation, she was she had a negative myocardial perfusion scan, and the pain resolved, and so we did not do anything much after that. Next slide, please. So in summary, her medical conditions are as follows. She had made a good recovery from the ischemic stroke. Hypertension is well controlled. The LDL is 2.1 on very modest doses of statins. Could probably be better, as the guidelines now suggest that we should try to bring it down more aggressively. Her type 2 diabetes is well controlled at 6.5%. She's on metformin only for her diabetes, so possibly there are new drugs that we can try to arrest the progress of kidney function. She has microalbuminuria. UACR was 6.5 milligrams per millimole, which is for the normal range less than 3.5 for females. Yeah. Yeah, and the kidney function is Quoc is 75, and on MDRD, GFR is 62. We use Quoc normally for dose titration with NOACs. For MDRE is probably more prognostic. So she does have, on both counts, she has a mild renal impairment, CKD, very mild chronic kidney disease, but she's still on rivaroxaban 20 milligrams based on the calculations. So can we just go to the next slide? And then the next slide, I think this is, okay, the next slide. So these are the questions. So this patient has, yeah, sure.
So I think we want Professor Tan to take this forward as to how are you going to, what is the appropriate management plan for this patient? And I specifically asked this in giving you the consideration that she has had an ischemic stroke. Now, when a patient has had an ischemic stroke, we understand that we may want to use another molecule, but the fact that she has had several bleeding issues. So I think let's have a little discussion here as to what is your appropriate management plan for this patient, Professor Tan?
I think it's always a balance between stroke risk and bleeding risk. I think the Rocket AF trial is really really a stress test of among all the RCTs of NOACs. Indeed, the patients are at the highest risk. So I have actually no qualms about using rivaroxaban in patients like this with high CHEST score and high stroke risk. Because we know that the benefits in terms of bleeding reduction is qualitatively better, especially for intracranial hemorrhage. So I think there's no doubt in my mind that we should be using NOACs for this, and especially for, I mean, sometimes when you have patients have minor bleeding episodes or that can be solved, some doctors may want to migrate towards using what is thought of as a safer NOAC. Like rivaroxaban, but for me, I think if the patient is doing fairly well on the one drug, I do not think that a shift is really necessary. And the other aspect is, of course, that the patients with renal impairment, I think with rivaroxaban, it really is a trial that has been again stress tested in a substantial fraction of patients, proportion of patients in the trial have got a moderate renal impairment, unlike with the other trials. So I think on all fronts, it is a well-tested drug.
Yes, thank you, Professor Tan, because yes, Rocket AF had a mean charge of over 3 and 40%, more than 40% of them were a diabetic population. So I think your point is very well taken. I'd request to bring Dr. Verma in for this, and I think there could be no one better than him to answer this question, that what do you need to consider when prescribing a NOAC to a high-risk group with CKD and a low body weight? So I think if we can discuss this here about the reduced dose and how do you want to plan that?
Yeah, I mean, it's a very good question, especially in the Asian population. We may see a lot of patients who have diabetes, chronic kidney disease, but also are of relatively low body weight in comparison, let's say, to a North American population. And so I think it's a very relevant question. With respect to rivaroxaban, for example, the dosing is very easy. It's all based on creatinine clearance. So if you have a patient whose creatinine clearance is less than 50, you dose reduce. And that's it. That's all you really have to think about. And we have seen in a wide variety of patients, including in an exclusively Asian population, the performance of rivaroxaban dose reduction to 15 milligrams in the Asian population, for example, in the J-Rocket trial. And we saw that that dose was very, very safe, and we saw that that dose was very, very effective. So I think there's a large amount of evidence in the low body weight population that you don't have to further dose reduce beyond what you would do for creatinine clearance. And I think also for chronic kidney disease, it becomes very, very simple. It's all based on the creatinine clearance. And once you're less than 50, your dose is fixed. It's 15, and you don't need to worry about it or change it even as the creatinine clearance progresses. With some of the other NOACs, it becomes a little bit more complicated. You have to think about body weight separately. You have to think about creatinine separately. You have to think about other factors like, peak glycoprotein inhibitors, et cetera, et cetera. But with rivaroxaban, it's very straightforward.
Thank you so much. I think while we have spoken a lot about rivaroxaban, there was one thing which I did want to make a mention is all of us must remember that this molecule should be had with a full meal. And second thing, I wanted to make a mention what Dr. Verma and said it so wonderfully well. And I just want to reiterate that when you give a competing molecule, what you do when you give a reduced dose, for example, of apixaban, you reduce it by half. You make it 2.5, while when you give 15 milligram of rivaroxaban, you're actually coming down to 27% reduction. So I think it makes the case very strong to really understand the molecules well and how they have been studied in the randomized trials, and especially when we have so much of robust data in favor of this molecule, rivaroxaban. Professor Hsieh, I think I'd like to bring you in, and I'd want you to take this question as to what are the practical aspects of NOAC treatment that need to be considered in a patient with the worsening renal function. So I think we'll spend a minute or two here and then we'll move on, please.
First, I think it's very important to follow up the renal function during the clinical. So if we see the patient with worsening renal function, the first one is to consider the dose reduction is need. We know renal function is the major dose reduction criteria in all the NOAC. So first one is we need to consider the dose reduction. The second one is then we need to consider do we need to change the NOAC? We know with the Verma presented, we know two NOAC seem to have preserve renal function such as dapiglutide and the rivaroxaban. So if a patient had worsening renal function, we should consider we need to change NOAC or not. And the third one is important to search any factor can worsening renal function is very important, just like GI bleeding, anemia, or any infection, any other. I think I raised three important to think about the aspect of to a patient with worsening renal function. Thank you.
Thank you. I couldn't agree more. But before we conclude this session, I really want to bring Dr. Verma in with all his expertise. That what impact do you think that antenna results will have on clinical practice in SPAT?
Yeah, so I know we only have a few seconds, so I'll say that Antenna, as you recall, took patients with diabetes and relatively preserved renal function and looked at their renal decline and renal events compared to warfarin. And it very clearly showed, like all of the other evidence, that relative to warfarin, rivaroxaban was renal protective. It slowed the decline in renal dysfunction. And I think that's a key take-home message for everybody.
Sure. Can we have Professor Tan's slides, please? Yeah, so I think we've answered most of these questions, and I think for the want of time, if there are any question answers, we can take it from the audience before we move on. So I think if we have no more questions, Professor Tan, your case is done, if I understand.
Yes, I think it is done.
Oh, fair enough. So I think we should move to the next session and maybe request Prof. Peter to come in with his slides, and we'll now move on to something which I think all of us have been wanting to learn and get better on, and that's about COVID and thromboprophylaxis. So over to him.
Peter, we moeten... Even... Okay, I apologize. Do you hear me now? Yeah.
Yes, we do.
Okay, so in the past years, we've not been able to travel a lot. And so that's why I like to show my little country, Belgium. And in the middle of that little country is my university, Leuven. If we're able to travel again, you're very welcome to visit Leuven. Leuven has a very old university that goes back to 1425. And the only thing that it's older than its university is its beer. Stella Artois InBev is brewed in Leuven, and that goes back to 1366. And so you understand that is a very nice combination for a university town. But the world has been occupied, has been busy with only one thing, and that's been COVID in the past years. Indeed, COVID has been an unprecedented challenge to the healthcare systems worldwide. I must say, in Belgium, we currently face our 7th wave. And even though the severity of these cases is of a total different scale than in the first waves, we still have a dramatic impact on healthcare system, on healthcare workers, on frail patients. And one of the issues that became very clear in the beginning of the pandemic was COVID caused thrombosis, caused clots, and these clots and the coagulation was very important in the prognostic evaluation of these patients. Clots had many different phases. We had small clots, we had big clots, we had venous clots, we had arterial clots. So that was very, very clear. But what have we now learned with respect to anticoagulation? Well, there are a few very important lessons. The first very important lesson is that we've looked at D-dimers not only as a very useful marker to exclude venous thromboembolism, but we've looked at D-dimers as a prognostic marker for the severity of COVID disease. This graph nicely illustrates that patients with high D-dimer levels had a 50-fold higher mortality as compared to patients with low D-dimers. So D-dimers, activation of the coagulation as a important marker of severity. Second, we were overwhelmed in the first waves by thrombotic complications. We were overwhelmed. This is a Dutch study, and despite the routine use of thromboprophylaxis, we saw up to 40% thrombotic complications in patients. So despite usual doses of thromboprophylaxis, a lot of thrombotic events. And then next, we saw these thrombotic complications mainly in these patients who were admitted to the critical care, to the ICU patients. We saw thrombotic complications in patients who were admitted at the ward with moderate severe disease, but we saw the thrombotic complications, arterial, venous, catheter access thrombotic complications in patients at the ICU. And so very rapidly, it was clear that, well, should we adjust our thromboprophylaxis scheme? What this graph shows is the mortality rate in patients who did not get heparin, the green lines, and then in patients who got heparin. And there you already see that the prophylactic and therapeutic lines actually overlap. And there has been tremendous lot of discussion on how should you adjust thromboprophylaxis in patients at the ICU, in patients at the ward. So here there was, from a very large registry, not a significant difference, but then there is efficacy, there's also bleeding. So if you increase the intensity of the anticoagulation, you will also have more bleeding. So also in COVID, anticoagulation management was about the difficult balance between anticoagulation efficacy and anticoagulation safety, bleeding. Then last year came two important studies, or a consortium of studies, where they looked at therapeutic anticoagulation as compared to usual care thromboprophylaxis in critically ill patients. And the surprises were, the results were a little bit surprising, as there was no impact on the outcome of these patients. The curves, as you can see, are overlapping. There was no difference in organ support-free days between these two groups in patients who received critical care. In contrast, in the lower risk group patients and patients who were not critically ill, and that's this graph, there was an impact on the clinical outcome. There were more patients with therapeutically dosed anticoagulations who had reduced organ support. So more patients had less support when they received therapeutic dose anticoagulation. So a bit contrasting what we would assume was that the critically ill patient had no benefit, but there was definitely in these patients more bleeding. If you look at bleeding complications, severe patients bleed more than moderate disease patients, and usual care thromboprophylaxis patients bleed less than patients who get therapeutic dose anticoagulation. And so in the ICU patients, routine therapeutic anticoagulation was not associated with an improved outcome. In the moderate disease hospitalized patients, there was an impact on outcome, and there is an ongoing discussion on whether the clinical benefit is outweighing the increased risk of bleeding complications. And some guidelines may actually recommend therapeutically dosed anticoagulation in selected patients, where other guidelines are still a little bit prudent. Okay, so we give prophylaxis to hospitalized patients. That's the message. But what do we do after discharge? Well, after discharge, you may opt for prophylaxis in selected high-risk patients. And I want to show this very elegant study, the Michel study, a Brazilian study, where they used the prophylactic dose of rivaroxaban, 10 milligrams, and compared that to no anticoagulation post-charge in patients that were selected to be at higher risk for recurrence based on the dimers, but also based on a clinical risk score, the improved VTE score. And that's a score that is based on previous VTE, thrombophilia, immobilization, ICU, length of hospital stay. So higher risk patients get prolonged thromboprophylaxis. And on the right, you will see the outcome. You will appreciate that these patients who got extended prophylaxis, who got out of hospital prophylaxis, had a significant reduced outcome, an outcome that was composed of symptomatic but also asymptomatic thromboembolism detected by mandatory duplex and CT angiogram. So, yeah, if you select your patients right, your patients will benefit from extended thromboprophylaxis. We have to congratulate the scientific community. A huge number of clinical trials have actually been performed in the past years. These are only the studies with rivaroxaban. But if you look at the enormous amount of clinical studies, we've really, as a scientific community, as a clinical community, really tried very hard to control the outcome of the pandemic. And I think we also, as a thrombosis community, I really say that we've made a very significant contribution. So in my conclusion, with respect to thromboprophylaxis, it's universally recommended. The risk is highest in ICU patients, but somewhat paradoxically, intensifying the anticoagulant dose to therapeutic did not impact on the outcome of these patients, probably in part because of excess bleeding. The discussion now is, well, if we might go to some intermediate dose, and some guidelines actually recommend an intermediate dose for these patients adjusted to anti-10A levels. This is, for example, what the Belgian guidelines suggest to do in critically ill patients. But also there, further studies will provide us with more answers. In non-hospitalized patients, we do not routinely prophylax, and after discharge, we may offer prophylaxis to selected high-risk patients, and they're out of hospital thromboprophylaxis. Obviously, oral treatment has been validated in the Michel study with the prophylactic dose. 10 milligrams of rivaroxaban is really attractive. Very short on how to treat a DVT, how to treat a PE. Well, there I can be very short. Treat as normal, treat as a provoked DVT-PE, start with a parenteral agent, low molecular weight heparin. If your patient is critically ill, switch to the oral agents of your preference, and rivaroxaban is the most used agent for venous thromboembolism worldwide. Switch to your preferred oral agents in non-critically ill patients. So, dear colleagues, a very short overview, unfortunately still very relevant on COVID-19. What have we learned? Thank you for your attention.
Thank you so much, Professor Peter. I think that was fantastic, and we really spun off a lot of discussion. All of us have gone through this pandemic, and it's left us all hurt. And we all understand that by and by we learned it better, and we were able to save lives when we understood that the issue of thromboprophylaxis in our patients actually helped. So I don't know how it is in Belgium, but what I can specifically say from India, that when patients are discharged post-COVID admission, there has been a lot of confusion on the dosage of thromboprophylaxis, on the duration of thromboprophylaxis, and there is some inherent fear in certain patients, and they keep taking the drug, not realizing the harm that it can be done, and want to keep doing their D-dimers. And I mean, we would like to hear more from you on this aspect. In your clinical practice, how do you decide the duration of thromboprophylaxis in your COVID patients?
So, an excellent question. And so when we were overwhelmed with the thrombotic complications in the first wave, we prophylaxed in the hospital, and we routinely provided prophylaxis out of hospital. But what we've rapidly learned is that the hypercoagulability related to COVID, you have that first phase, but thereafter, in most healthy patients without comorbidities, that hypercoagulability is rapidly going away, and the number of out-of-hospital VTEs is low and is not routinely warranting the out-of-hospital thromboprophylaxis. So the out-of-hospital thromboprophylaxis is really to the targeted patients at high risk because of a history of VTE, because of continued immobilization, because of familial thrombophilia, because of immobilization. But the average patient that is recovering from COVID-19 and is rapidly recovering, that is not a patient where we thromboprophylax out of the hospital. And how to prophylax? You can choose a low molecular weight heparin as a good choice. We give the high prophylactic dose, 50 units per kilogram. The prophylactic doses of the DOACs, such as Riva 10 milligrams, is also an excellent choice.
Would you also like to highlight on your choice of molecule, especially in COVID thromboprophylaxis?
Sorry, I missed your question.
I'd like you to talk about your clinical experience, your choice of the NOAC that you would want to choose, because we have a lot of randomized data for SPAF and NOACs. We may not have as much robust data with COVID thromboprophylaxis with NOACs. Let's hear from you.
Yeah, well, here I would say, if you opt for a NOAC, opt for the NOAC of your choice, the NOAC that you are most familiar with. I must also say here in venous thromboembolism, the best studied NOAC is rivaroxaban. And I've just showed the very many different trials in the prophylaxis with rivaroxaban that were carried out during the pandemic and that have helped us. They've clearly indicated what the role was of DOACs as compared to low molecular weight heparins. I think very carefully what you can say is that in hospital, especially for critically ill patients, a parenteral drug may be the preferred choice. Out of hospital, it is definitely a DOAC, Riva being the most studied, but if you're used to work with other DOACs, I think that is also fine. If you treat your patients with DVT-PE, treat them as a provoked DVT for at least 3 months. If your patient at that time is in a good shape, well recovered, no continuing risk factors, that's an appropriate moment to stop anticoagulation. If there are risk factors that continue to be present, you can obviously extend anticoagulation at that moment.
Thank you so much, Professor Peter. And I think with this, we come to the conclusion of this wonderful session. And I'd like to thank Professor Verma, Professor Tan, Professor Hsieh, and Professor Peter. And also would like to share that while we've all learned so much about the role of rivaroxaban in our patients with diabetes, with and without worsening renal function, I want to make one last point that we do have a lot of emerging data which suggests that rivaroxaban may help not only reduce stroke, but also diabetic complications in patients with atrial fibrillation throughout the body, because we do understand it does something on a vascular bed compared to VKA, as a result of which reducing the ophthalmic outcomes, renal outcomes, limb outcomes, vascular death, and stroke and systemic embolism. I think with this, we come to the conclusion of the session, and I thank each one of the delegates. And I'd like to thank Bio for bringing us all together on this platform, and all of us coming together and learning so much from each other. Please feel free to going back to your geographical portal on this Navigate web portal, and we're all happy to connect with you, come back to you, and all of us learn better. Before we conclude, I think it makes a good reason that we do go back to the polling question, which we did begin with. Have we learned that in our patient with non-valvular atrial fibrillation, a comorbidity such as diabetes is important enough reason for us to evaluate our choice of NOAC? So I think we would like to see what all of us have learned together, and let us all poll and come together unanimously on this question. So it's wonderful to see and good to believe that the answer this time is 100%. So we've moved from 60% to 100% that we believe that diabetes is a reason enough for us to evaluate our choice of NOAC, having learned so much from Professor Verma on this specific subject. I think we have another polling question. And how strongly do we all now believe in the scientific data and the benefits of rivaroxaban for our non-valvular AF patients with diabetes and renal impairment? We've all answered these before. What have we learned from the speakers just ahead of us is, have we learned that we strongly believe, somewhat believe, am not aware, or I don't see a benefit with rivaroxaban in this patient group? So let's see what we have the answers here for this question. Wonderful. So I think all of us agree that we strongly believe in rivaroxaban simply because there is enough data in favor of rivaroxaban. And I'd like to bring in Professor Verma and see if he has any more comments to give before I conclude.
No, thank you very much, Dr. Jaswal. I think this has been such a great session. I know I've learned a lot from my colleagues, and we've had a chance to share a number of items, but hopefully we have seen both in the VTE world and also in the stroke prevention world with atrial fibrillation that there are some key differentiating factors with rivaroxaban that certainly helps in the higher risk diabetic chronic kidney disease patients.
So thank you so much. I'd like to thank each of the delegates. I'd like to thank the panel, the learned speakers here, and of course Bio for coming and bringing us all together. And with this, I think we conclude. Thank you so much for being with us.